Welcome to the Dusty Muffins, where menopause meets sisterhood and strength. We're three menopause specialists coming together to laugh, share, and empower you through the wild ride of menopause and perimenopause. Whether you're curious, confused, or just looking for real talk, you're in the right place. We're here to answer your burning questions, educate, and advocate, all with a dash of humor and a lot of heart. So pull up a chair and join the conversation. Before we dive in, please remember, while we're doctors, we're not your doctors. This podcast is for educational purposes only and is not a substitute for medical advice. We encourage you to partner with your own medical clinician to address your unique health needs. This is the Dusty Muffins.
Welcome to the first episode of our podcast, The Dusty Muffins. Today's episode is titled The Perimenopause Puzzle, Understanding the Symptoms and Solutions. The goal of this episode is to demystify perimenopause symptoms and empower you as listeners. I'm Aoife O'Sullivan. I'm a primary care doctor and I specialise in menopause care. I live in Portland, Oregon. I'm originally from Ireland. Did med school and residency in Ireland, moved over to Baltimore, Maryland, and did a second residency. Lived there for 12 years and moved to the West Coast about 10 years ago. I practiced most of my career not knowing anything about ovarian neuroendocrine hormones, which really was detrimental to my practice of medicine. I feel like I was missing volume 2 of everything you could know about women. And so learning all of this changed my life. And that is how I met my two fellow Dusty Muffins, Dr. Hart Kress and Dr. Hertel. And the three of us talk so much every day, every week. We thought, you know what, why not put all this into a podcast for everyone to learn from as we go along.
Hi, I'm Dr. Christine Hart Kress. I'm a board-certified women's health nurse practitioner. I hold a doctorate in nursing practice, and I'm also a menopause certified practitioner. I retired from the Air Force 5 years ago, and through my own perimenopause experience, found myself needing to gap some of my education, and so embarked on a 2-year journey to learn everything that I can about midlife health. I've been practicing for over 3 decades, and so I went through the Women's Health Initiative in that fateful day, and so we've come a long way since then, and I found that it was also difficult for me to get my own care, and that is why I focus on midlife care, because it just shouldn't be that hard for women to get the care they need.
Hey everyone, I'm Dr. Rebbecca Hertel. I'm a board-certified osteopathic family medicine physician and a certified menopause practitioner. I've been practicing medicine since 2009, from birth until end of life, and midlife women, although at the time not doing such a great job until I started going through my own journey and realized that I had absolutely no idea what was going on with myself, and that other women definitely could be not understanding what exactly they're going through either. So embarked on this same journey, a ton of education, all of the things menopause and midlife, and became a certified menopause practitioner and met and worked with these two lovely women here who are definitely my Meno besties. And here we are making sure that educating and advocating for midlife women and really all women, so that you all can take control of your health and your future. So here we are.
I think we're going to start at the beginning and just differentiate between perimenopause and menopause and what that is, because I think even the three of us had never really come across the term perimenopause, right?
Right.
Correct.
I had no idea. I don't remember being educated or quizzed or tested, or even hearing that until, the last probably 3 to 5 years.
Yeah. And even in my training, I remember menopause being boiled down to vasomotor symptoms. So hot flashes and night sweats and your period changing. And that was pretty much all I knew as well. So this term perimenopause was an eye-opener.
Especially when you're going through it and don't realize, because you don't have hot flashes, what it is, or that there is a thing. And then you find yourself down this rabbit hole of trying to fix individual symptoms and no one being able to connect all the dots and realize that it's all because of those darn ovaries going into retirement a little bit early.
Yeah, they go out on the dance floor and then they come on back out and then they walk out on that dance floor and then they walk back out, and they're like, "Hi, it's me. Hi, it's me again." Like we're gonna wreak some havoc for just a little bit longer. We're gonna make your period funky. We're gonna make you have some joint pain. We're gonna, and then we're gonna shy back away and just like sit back and watch what you do from from what we've done to you.
Because in our practice, I think we would all say hot flashes and night sweats are not what most of our patients come in with.
No, and I don't think for myself, although they sucked, it wasn't as bad as the other stuff that was going on. Like really the thought of that I was just losing my absolute mind at myself and everybody else around me,
Mm-hmm.
Yeah.
Yeah, it's a number one thing that I'm now seeing is women as young as late 20s to mid 30s finding their way to certified menopause practitioners because they know things aren't right. And what they keep hearing, whether it's their OBGYN or their primary care doc, they're hearing, "You're too young. Let's put you on an antidepressant because mood usually shows up, or let's put you on birth control because that will fix everything." And, women now, I mean, they're getting a PhD in perimenopause and menopause, and they're like, I know that is not my only option.
Yeah, right. Exactly. And I guess, for our listeners, let's just go back real quick about and explain what perimenopause is. And, and I can take a quick minute and you ladies chime in. And so, perimenopause is that time around your period. You're still getting cycles, whether they're regular, they're irregular, they're heavy, or they're light. And, menopause is that 12 months and 1 day without a period. But peri can last, months to years. And so, yeah, like you said, we're finding these women they don't get it because they were taught, as we were, is menopause is when you're done having your periods. And you're like, well, that ain't so bad. Okay, that sounds fantastic. Well, no one said that this merry-go-round where, that fun little kid, like, takes everybody around and doesn't stop and you're all holding on for dear life, that is what it was going to be like,
I love that gif.
Yeah. Yeah. Right. Everyone's holding on and each person flies off one at a time off the merry-go-round. So yeah, so that, that's how it differs from menopause. So this could be years of really not understanding and searching for answers and going to your different doctor after doctor after doctor to try and figure out, what the hell is happening to me.
Right.
Years ago, sorry, Christine, they came up with this way to differentiate women into different categories for research purposes. Who was menopausal, who was not menopausal. And it was supposed to be for research purposes, but I think it has become a guideline for a lot of clinicians and become quite detrimental for women because it breaks the menopause transition, which is from the beginning of any perimenopause symptoms up until years after your last period. So that's the whole transition, all your symptoms, all the time, everything's changing. But really, it gives the impression that it's all based on your periods. And so I know we all do see so many patients who've gone to their doctor looking for help and have been told, but your periods are normal, they're regular, so you're not in perimenopause. And it couldn't be further from the truth, could it?
Absolutely not. And I mean, they say, on average, it can be up to 10 years before that final menstrual period, and on average, 4 to 7 years, which I don't know about you guys, but I've about done up and over this perimenopause. That's been hassling me for about 8. Aoife, I love your explanation of what's happening to your ovaries and your follicles. Will you hit that?
Oh, yeah, absolutely.
Like,
So, unlike men who make sperm every day, women are born with all the eggs in their ovary that they'll ever have. And when we're born, that's probably between 1 and 2 million eggs. And then by the time you get to your first period, so for a lot of girls between the ages of about 9 to 14, you're down to about 250,000 eggs. And that has to do you then for the rest of your reproductive life. And for some women, they come towards the end of that egg supply in their late 30s. And for other women, it could be their 60s. You meet women in their 60s who are still having a period every month.
Yeah.
And so what happens is for the first 2 weeks of your cycle, so day one of your cycle is the day you start bleeding. So for those first 2 weeks, you start to bring eggs to the surface of the ovary, multiple eggs. And all the supporting structures that support those eggs, they produce hormones, and estrogen is the big one. And so you get this nice big wave of estrogen for the first 2 weeks. And then when it reaches its peak, it actually causes, in a way, the release of that egg. And that's around day 14 for most women. And then if you don't fertilize that egg, if a woman doesn't get pregnant, the supporting structures that were around that egg, they collapse down and they form something called the luteal body. And that produces progesterone for the next 2 weeks. And so the whole way through our reproductive life, we get those lovely cycles of estrogen and progesterone. For some women, that causes problems throughout the month. They'll have symptoms they don't like coming up to their period. And feel better once their period starts. For a lot of women, those waves don't bother them at all. They don't notice them. But then as our egg supply decreases, we don't get that lovely release of the egg every month. We don't get all those eggs coming to the surface every month. And so we're not getting those lovely waves. And instead, we're getting spikes and troughs. And our bodies, it turns out, and our brains don't respond well to peaks and troughs of hormones. Mm-hmm. They respond well to nice waves or things being nice and steady. And so that's where we get all our symptoms from. And almost every cell in the body has estrogen, progesterone, and testosterone receptors, and they are there for a reason. And so when they don't have a molecule of hormone in them, they don't like it. And that's how we get all our symptoms.
mm-hmm. Yeah, I mean, 50 million women right now are going through menopause, and you'll enter perimenopause. There's only one way to not go through perimenopause, and that is to not be here to do it. And so, it's really, really discouraging, that the number of women that will go to seek treatment, and it's something along the lines of like 70% of women will go to seek treatment and not actually get care and have about a 10% chance of actually finding a provider who is well-versed and able to have an educational discussion, let alone, will be willing to treat them. I mean, and that's really sad, because really what happens, there was a study that they put together, and it said, that women will get, who aren't getting treatment, will get like the equivalent of 1.5 million more outpatient visits per year. And I'm sure you all, as family medicine, primary care docs, you can attest to the number of people who come in wanting, with all of these symptoms.
Oh yeah, absolutely. Especially in those, I think what the last number of women entering or over the age of 40 was 80 million, so you think that a lot of us are seeing a lot of that where they're just coming in and it's anxiety, it's depression, they're not feeling well, they're having palpitations, something's wrong. It must be their thyroid, right? That's usually what they're asking. And so it's not a small population or percentage of women that this could potentially, affect. And it doesn't mean that they're all going to have, the same symptoms, worse symptoms. It's such a myriad, right, of symptoms that these women are getting, but it just happens. It creeps up on them, and they just aren't realizing what in the world it is. And then when they do go into their provider and they're like, I think that's what perimenopause is, they're like, well, you're still having a period, aren't you? Or
Mm-hmm.
your hormones look fine. They look fantastic, right? And then they're turned away, or they're given antidepressants, and they're definitely not validated on, on what it is that they're feeling. And, to a detriment for some women, especially those with that really suffer from anxiety and depression, and increase in suicide rates in that group of women.
Mm. Will we go through and talk about all the different symptoms that women can have
Yeah.
during this transition? Okay.
Yeah.
Yeah, absolutely. I think that's a really great thing to kind of dive back into. Or what are, like, let's maybe break them up into what are the physical symptoms that your ladies come to you with?
I see a lot of sleep, anxiety, irritability. Women really having trouble with focus, especially at work. Feel like they're always marching from one task to the other and don't feel like they can function, like their higher executive level functioning isn't as well. And, a lot of it is from sleep disturbances. And then, of course, everybody with the weight gain and just feeling tired. Those are the main ones, that I see I can usually pick out the ones that most women are going to tell me. What about you guys? What other symptoms do you guys hear a lot?
Yeah, it's amazing how many brain symptoms they are. Like, we talk about them as if mood is kind of a psychiatric thing, but it's the brain. These are all brain symptoms. How dare we not know about these? Or how dare they not teach us about this in our training? This is insane. All those hot flashes and night sweats are from the hypothalamus in the brain, libido from the brain, mood, anxiety, depression, sleep, irritability, rage, lack of self-confidence, all from the brain. So much involves the brain. And then you have, let's say the skin. So a lot of women, as we lose our estrogen, it really affects the production of collagen and elastin in our skin. And so what women will notice is that their skin is becoming dry and itchy. That can be just generalized, or it can be in patches. A lot of women complain of having itchy ears. And then, estrogen is so anti-inflammatory that when we lose it, we get all these inflammatory conditions too. So people will say, I had eczema as a kid. I have never had it since. And now I have it back. I have rosacea. Rosacea is a big one, and we think there are explanations behind rosacea that we don't understand, but whatever they are, they're definitely affected by loss of estrogen. That definitely makes things worse for women.
I think that's so interesting that you talk about the rosacea. And I think it's the difference from being in an OBGYN clinic versus primary care, because I'm like, no one ever talks to me about that. And now that you point that out, I'm like, you're right. But I don't get those complaints in an
You're
OBGYN
at the wrong
office.
end of the table, Christine. So your face is at the wrong end.
It's kind of cool because, I mean, I think that's a little bit of the difference. Or even like the cardiologist, like how many women get their $1 million cardiology workup for heart palpitations? Like the cardiologists need to know about that symptom.
And
or
that's
the
in
ENT.
perimenopause. It's not just menopausal.
Right. All the ringing in the ears. Like, it's like women get sent down this ologist hunt. They go to the rheumatologist for their joint pain and the gastroenterologist for their stomach. Like, I think it really begins with that primary care provider understanding how all of those symptoms are tied together, and that, if you don't treat, that's okay. Though now I have some thoughts that I really think, and I'm going to say this out loud. I really think in 2025, if you don't know somewhere to refer or are unwilling, that you probably shouldn't be taking care of midlife women.
100%. Absolutely. It's come to the point now that this is talked about. even though we have a menopause space that, I know we're in a bubble, it's not that much of a bubble. There are documentaries out. It was on PBS, there are books out there. It's been on, Oprah talks about it all the time. Drew Barrymore talks about it. All of these women are talking about this. It's on the Today Show, and our colleagues have been on the news, and we've all been on the news. I mean, it's out there. So this is the point where you're right. Like, you don't have to treat if that's not what you do, but you damn well better make sure that you get your patients where they need to go so that they're not suffering,
And to speak to
big.
sorry, Rebbecca, speak to that point as well, Christine, I just feel like it makes our job so much harder. Like, when a woman who never comes in to see me except for her yearly exam suddenly starts coming in every month with tendon and joint problems, with mood problems, and I'm faffing around trying to find answers, spending a ton of money, and she has all those copays, trying to send her, like you said, to different specialists and get to the bottom of everything. And if I had that information, it would make my job so much easier. It just makes everything more difficult for the patient and for the clinician. And you're right. I really think 2025 now are, women know all this information. So if you have women coming into you and you're just refusing to look into this or learn about it,
you're missing.
Yeah, you're missing out. You're
are.
making life harder for yourself, really. Yeah.
Yeah, and like you said, all those hormones that are involved with estrogen, testosterone, progesterone, working on dopamine and serotonin and acetylcholine, and and blood flow. I mean, this is from head all the way to toe.
Yeah.
In peri.
And I think, for women, if you're finding that you're, going to 1, 2, 3, 4, 5 appointments, sometimes providers, things that you can do to kind of set yourself up, tracking your cycles, tracking all your symptoms. We really like the green climacteric scale. And if your score is greater than 15, you probably need some hormones back. Depending on your symptoms is going to be your hormones. But, I really think it's kind of a sad state of affairs. But I will say, from coming from a GYN practice where I did an annual in 10 to 15 minutes, a new patient in 20, it wasn't enough time. And frankly, when I had someone with perimenopause or menopause come in and, and then the tears started flowing because everybody cries at the gynecologist's office. Frankly, as a provider, I felt panicked because I'm like, I can't do it all in
You're gonna get behind.
minutes. Right. And so really, if you're going to make an appointment, either with your primary care or your OBGYN, make a separate appointment just to talk about that, because first of all, you're still going to have to pay a copay because it's not covered under a wellness visit. Don't blame me. I'm not the insurance company. You're still going to pay a copay for it. So trying to slide it in isn't going to matter. But then it gives your provider the opportunity to have the 10 or 15 minutes, which is not enough, but at least you get focused on that. Because in an annual visit, I don't know about you guys, but I'm like checking off, okay, I've got mammogram, bone density study, colonoscopy, and then I really want to know if you're having bleeding or, vaginal problems. So those would be kind of my tips for women to set yourself up. What do you guys think? Anything else you'd add?
They're great tips. I always love to tell my patients about Dr. Louise Newson over in the UK. She is a menopause specialist, and she has set up the most beautiful website, jam-packed with information for anyone in the community or clinicians. And then she has an app as well, which is free, that you can stick on your phone and use it to track your symptoms. So you can see if certain symptoms are bothering you at certain periods during your cycle, and what's coming and what's going. And especially if you start on any hormones, to see what improvement you're having.
Yes, I agree. And ladies, it makes it only not only makes our job a little bit easier when you come with, and it doesn't have to be a woo-woo journal unless you want it to be, but when you come with things written out for your clinician, this is what's going on, this is cyclic, this is happening to me, I didn't have these things before and I've been watching it, boy, it sure makes things a little bit easier. And sometimes when I get these women in perimenopause, sometimes that's, once we have this long discussion about everything, that's what we do. They don't even go away with necessarily any medication. They just wanted the knowledge, wanted the information. And they're like, you know what? I actually feel okay right now. I'm going to just go journal for like the next 1, 2, 3 cycles and then come back if I need something. And so, there's nothing wrong with that either. Sometimes just having the conversation, the validation, the education is so empowering and enlightening.
Yeah, and knowing that your clinician listened to you. Like I hear that all the time. Thank you for listening to me. I never know even what to say. Like it's just such a basic thing. You're thanking me as your doctor for listening to you. I mean, that's a low bar, right?
Yeah.
And
Right.
not blowing you off. That's a really low bar.
I agree.
It's sad.
And I think too, if you want to be even a little blazing, all three of us on our Instagram pages have our link tree is chocked full of articles. Print a couple off, like the contemporary view on hormone therapy,
My
menopausal
favorite
hormone therapy, and bring it into your provider. I'd have it in your hip pocket. And I would be bold enough in 2025 to say, here's an article. I'm going to schedule another appointment with you. After
another article is Dr. Vonda Wright.
Love that one.
What brought one out this year and also paid for it to be open access, so it's not hidden behind any paywalls, called The Musculoskeletal Syndrome of Menopause. It's fabulous. And they're the 2 articles that you need really in your pocket. Yeah.
Yeah. I tell my patients, print that. I just was saying it last week, print it out, take it to your ortho, take it to your physical therapist, take it to your family medicine physician, whoever it is, or they can actually look it up themselves too. But if you actually hand it to them, then they can't run away from you and tell them they're going to do it later. So
no, not at all.
The resources are there, in this perimenopausal space, there's so many options for you. It's not inevitable to feel bad. Sometimes it's hard to pick apart what is perimenopause and what isn't. And it's hard for us sometimes too, and so it's nice to jot those things down. And then you can have that discussion with your clinician on, what is going on with me. This is cyclical. I never was like this, and now I am. And really women want to know, is it safe to be treated if I need it? And they're not necessarily depressed. They don't want an antidepressant. And that's not always the answer for them either. And so, you don't have to wait until your symptoms are bad enough. You don't have to wait till you're done with your periods. You don't have to wait until, you can't just get yourself out of bed to even, go to work that day or take care of your family.
Yeah. Let's briefly go over sorry, Christine. Sleep disturbance. I'm looking at our notes that we made so we wouldn't miss anything. So sleep disturbance, weight gain, metabolism, and then we didn't talk about GSM at all. Genitourinary syndrome of menopause. We could leave that for another episode, but we could just briefly mention why it happens.
Let's take a minute maybe and go over all those real quick just for everybody.
Yeah, I mean, I think, weight gain, is it inevitable? Sure feels like it for the majority of women. From the loss of estrogen, we see a redistribution of fat, that subcutaneous fat, which is the fat that gives us hips, gives our hips and thighs some curves and some little dimples that we don't like in the mirror. Often will then shift to the middle. And a lot of women are like, my pants feel too tight. I feel like I've got a big bulge. And, women can gain anywhere from 1 to 15 pounds a year. One of the things that's happening is not only as the estrogen's declining, you're shape shifting and moving that fat around. And we worry about that visceral fat because that's the fat that's around all your organs. It increases your risk for cardiovascular disease. We see an increased risk of diabetes. We'll see that pre-diabetes where your hemoglobin A1Cs, which look at your sugars the last 3 months, start to climb, but also things like endometrial cancer is more common when you carry more of that weight around your middle. But at the same time, your hunger hormone ghrelin drops as estrogen, or increases as estrogen drops. And then your leptin, which is your satiety hormone, that decreases. So you've got increasing inflammation, your hunger hormone's up, your full hormone is down. And so that weight gain is very, very, very common. And, hormone therapy will decrease some of the inflammation. And sometimes women will lose weight when we fix their declining estrogen levels, but not all the time. It's, one of the number one things that women come and, talk about after we get some of the other hormones dialed in.
Do you want to do GSM, Rebbecca? Just to explain
sure.
briefly.
Yep, I'll briefly go over that. So I do get a lot of perimenopausal women that don't understand, because I think they think that the genital urinary syndrome of menopause or vaginal dryness is probably the question that they don't necessarily talk about, that not enough providers ask about. And it can happen as one of the first symptoms of perimenopause. I have a lot of women who they have no libido, they have painful intimacy and vaginal dryness. And that's because that area down there, in the vulva and vagina, they have a lot of estrogen and testosterone receptors. So as those fluctuations occur, sometimes it's just that week before their period when everything is low that they're feeling those symptoms. Increased urinary frequency and urgency as well, because that's all related. And it can happen in perimenopause. I see it a lot. And that is because of those fluctuation of hormones. So it's not just you. If you're feeling like, man, I don't really want to be intimate with my partner, or it kind of hurts, but not all the time. Is it just me? No, it's perimenopause. It's that roller coaster when those drop down, or as it slowly is going down, that area gets affected, and it really, and it can be treated very easily. And we usually will start with just some vaginal estrogen if we're not going to do systemic hormones to begin with, and just a little vaginal estrogen, which is local to the pelvis. It does not go systemically, can be such a game changer for women to keep everything nice and plump and more like a grape and less like a raisin.
No, I like that. I like that analogy. What
they get it. They're like, oh yeah, I don't want a raisin.
What are you hearing women talk about with treatment options? What are you hearing that when they come, by the time they come to you, what they've tried or what they want or what they've been told no about? What are you hearing, Aoife?
Well, I live in Portland, Oregon, so everyone here has a naturopath. So they'll often have been tried on a selection of items, be it supplements or hormones. And I think at least somebody is trying to help these women, because they come to us, regular Western medicine docs, and are not able to get any help. And so they look outside that then. But what I find here is that even though they are trying to help them, their knowledge about all of this is quite limited. And so they're able to start somebody on hormones. But then if that particular, type of, like if it's a gel or a patch or a pill, and that doesn't suit that woman, then they don't know what to do next, because they're not really sure of the options available and how to finesse the treatment. So, and again, a big knowledge gap. But most women I would see here in Portland have a primary care doctor plus or minus a GYN doc and a naturopath or a chiropractor.
There.
Yeah.
I see a lot of women coming to me on birth control pills, and they've been to their provider, and the patient is, or the woman is still having symptoms. And I remember, even what I didn't understand, and it was Kelly Casperson that said it so well that it kind of clicked in my mind when she talked about that estrogen, progesterone, and testosterone are chemical messengers that tell organs, cells, and tissues how to function. And when you don't have those messengers and it's like staticky, it's getting every third word. And I was like, well, if I'm giving birth control pills, which are higher, even the lowest dose of birth control pills are higher than the highest dose of hormone therapy, there is no way that this woman is having symptoms. Like, I used to think that, GYN, I did annual, 100, 200 annuals, over the course of, 10 days. And I was like, it just doesn't make sense to me. But the birth control pills are shutting down the ovaries. So if you were to draw an estrogen level, this is why we don't, on birth control pills, it would be really low. So the synthetic hormones in the birth control pills, like ethinyl estradiol, they don't go and sit on those receptors. Their job is just to shut down the ovaries, make your periods go away. And my personal philosophy is life is too short to bleed unless you're trying to make a baby. Nobody should bleed. And then, and so when I heard Kelly kind of talk about that, and then I kind of I was like, well, now I get it, because what the body is looking for is the delta between what your ovaries are producing and what those receptor sites are looking for. And when you load the estradiol on top of those receptors, or the progesterone or the testosterone, it's like the whole message, like everything is complete and the symptoms start to go away.
Yeah. 100%. I was trying to make a little list there of key takeaways from this episode for people.
Yeah.
If they,
let's go. I think we're about ready for that.
Yeah, I made a little list. So first of all, number one, I would say we all have Instagram accounts on which we share lots and lots of information. We have, like Christine said, fantastic link trees. So that is step number one. Have a look at our link trees and pick out those papers that are going to help you get what you need. Step two, have a look at the Balanced Menopause website, plus or minus the app. We are not sponsored by them at all. Just find it so helpful and such a great source of information. And then also, when you're going to go to your clinician, to make a separate appointment so that you have time to talk about all of this, bring some information with you. And have kept a tracker for 2 or 3 cycles so that you can clearly say, this happens the week before my period, or whatever makes sense for you. And then if you don't find help during that appointment, I think you really do then, because you can't just keep suffering. This is what women have been doing for the last 20 years, just suffering in silence. So we're done with that. So if you've had a good conversation with your clinician and they're not open to helping you or learning more or referring you, then I do think you need to look further and find somebody local who can help you, or online. Any other takeaways you guys can think of?
I think that's perfect. And I think, one thing I would say is just give yourself some grace and don't be so hard on yourself that you are not going crazy, that this is validated. This stage of your transformation, your midlife transformation is something that we can or someone can help you navigate. You don't have to do it on your own. So give yourself grace and walk into it with confidence, knowing that find someone that will help you, and do not settle for anything less.
Yeah, I absolutely agree. Read and educate. Every woman should read the book, Estrogen Matters. It just helps pull so much together, and then there's the new Pause book. And then, of course, You Are Not Broken. And we're going to talk a lot more about what sex is like in perimenopause, and how our sex education was not the same as those that we bore. So we'll talk about that in a future episode. But you don't have to do this alone, and do not suffer. Don't suffer.
No, we're done with suffering. And our next episode, we're planning on talking about the Women's Health Initiative study, which is what happened 20 years ago that brought women's midlife healthcare crashing to its knees. So that's what we're talking about next.
So thanks for tuning into the Dusty Muffins. We hope you laughed, learned, and felt a little more empowered on your menopause journey. Don't forget to subscribe, share, and leave a review to help us spread the sisterhood and strength. Got questions or topics you want us to cover? Reach out. We're here for you. Until next time, keep thriving, keep laughing, and remember, you're never alone on this wild ride. See you next time on the Dusty Muffins.